Welcome to another session of Voices in Health. I'm your host, Thomas Mehigan. Today we'll be discussing consequences of overuse of antibiotics and how Washington Hospital is working to combat the problem. Antibiotics are part of a group of drugs known as antimicrobial agents. These agents, penicillin for example, are capable of destroying or weakening certain microorganisms, especially bacteria or fungi that cause infections and infectious diseases. Antibiotics have been hailed as wonder drugs that not only can fight back lethal infections, they can save lives. But the Center for Disease Control now estimates 20 to 50% of all antibiotics prescribed are either unnecessary or inappropriate. The overuse of antibiotics has resulted in new microbes that resist the effects of antibiotics themselves, and this can put patients in danger of side effects and even of introducing antibiotic-resistant bacteria into the community. To better deal with these issues, Washington Hospital has joined a nationwide healthcare movement by assembling an Antimicrobial Stewardship Committee to help protect patients and the community from antibacterial overuse and antibiotic-resistant superbugs. With me are Dr. Dianne Martin, head of the Antimicrobial Stewardship Committee, and Lina Huang, pharmacist and co-chair of the committee. Welcome to you both. Dr. Martin, would you tell us what the Antimicrobial Stewardship Committee is and why are antibiotics such a hot issue these days?
In our hospital, we were seeing that antibiotics were not used as effectively as they could be. We were also seeing we had increasing resistance among staph infections and other bacteria. With that and the support of administration, we formed a committee. And we felt the committee should be multidisciplinary. So it includes pharmacists, nurses, laboratory personnel, administration, quality people, and infectious disease physicians, critical care physicians, to get together as a group to address these issues. Originally it started because we were seeing inappropriate use of certain antibiotics and unfortunately very high resistance in a lot of our bacteria. So we had great support from administration to form a committee to help provide education about appropriate use of antibiotics. So our focus was on education, but also helping to make appropriate or tailor the use of antibiotics on a person-to-person, patient-to-patient basis.
Why is this such a hot topic? I mean, I turn on the radio, I'm hearing commercials about it. The general public has really gotten into the idea that we've got to do something about microbes, bugs, and ourselves.
It used to be these drugs were miracle drugs and always worked. And now we're seeing these drugs are not working. And we're seeing patients die from these infections, and we have no resources to offer them. So I think we need to target those kind of superbugs, the ones that are resistant to the common antibiotics as well as the stronger antibiotics, and figure out how we want to approach this. So we want to make sure they're used for the right infection, for the right duration.
The problem with antibiotic usage has become more complex. In the beginning, like Dr. Martin was saying, in 1960s, 1940s, we have antibiotics that we can use. You yourself had mentioned that you receive penicillin for any ailment that you had. And because we use so much of antibiotics, we basically teaching the organism to come up with a defense mechanism. So now we have come to an era where there are so many of these resistant organisms to the point that the antibiotics that we have in the market may not be able to deal with this organism. It has been recognized nationally and internationally as well that this is an issue that we all have to deal with, and it does require an interdisciplinary team to really look at how antibiotic is being used. Now antibiotic usage require expert. When we mean expert, it's not just an infectious disease expert. Infectious disease physician like Dr. Martin can provide information about how to deal with the illness, but because of the resistant mechanism, it's so diverse. So you do require pharmacists to make sure that the selection of antibiotics is appropriate as well as the dosing is appropriate. You require nurses to help us with preventing a patient having the infection to begin with. So now instead of having one person able to take care of an infection, like in the past, now it does require an interdisciplinary team who will look at problem from many different angles and be able to take care of patient appropriately.
So not only are we worried about doing the right antibiotic for the patient, if we do the wrong antibiotic, there are consequences, perhaps to the patient, he won't be treated properly, but also perhaps to everybody else around.
Sometimes that means saying no. A patient may come in and say have a cough or an upper respiratory thing that's clearly viral. And many times patients, families, moms that have got little kids that are sick, they want an antibiotic thinking it's going to fix this. When you want to say, no, this is not the right thing to do. The antibiotic would not help you and might actually induce resistance in your own bacteria that for a later time may make your infections much more complicated and more serious and more life-threatening than it would be if you had not gotten that antibiotic.
Now, when I have a patient that has an infection, I frequently say to him, let's get a culture. What does that mean? What are we doing when we say, let's get a culture?
One of the ways that we try to target antibiotics and make sure that they're used appropriately is to find out what the specific bacterial or viral or fungal infection is in the patient. So with a culture, we're taking a sample of the infection and we take that to the lab. They look at it and culture it and try to figure out, once the bacteria grows, we then match it to the antibiotics we have available to see what's the best treatment plan.
In particular, we use the word superbugs and resistance and all that. So what do we mean by a superbug?
Usually a superbug will have resistance to not just one antibiotics, but to multiple antibiotics. And that causes problem in terms of selecting an antibiotic for a patient, especially if a patient is severely ill and we do want to cure the patient. We run out of choice.
In the old days, I used to give antibiotics to a patient, and if it didn't work, I'd switch to another antibiotic, and then another antibiotic, another antibiotic. We rarely asked for help. Now, can we identify the superbug in advance? What happens now? Can we find out about superbugs right away? You have to wait until the battle's over, and then we call it a superbug.
Many times we look at the patient's background. Are they somewhat immunocompromised? Have they been in the hospital before? Have they been exposed to antibiotics before? Have they come from nursing homes, which would predispose to their having resistant organisms? We also have in our hospital, that's specific to our hospital, an antibiogram. If you're suspecting a particular type of superbug, you can look to see which one is most likely to give you most coverage for that particular bacteria. Also, as the physicians are choosing an antibiotic, there's an automatic drop-down box so that you can look to see what you think you might be treating and what the most appropriate antibiotic would be for that particular bacteria.
Since the Stewardship Committee was invented 5 years ago, I've stopped treating all infections myself. So now I asked for the Infectious Disease Committee, or infectious disease person, to come by and help me out, because antibiotics are so complicated, the bugs are so smart, some of them are superbugs, that I just don't take it upon myself to make those decisions. But how common is it for a patient who comes into Washington Hospital with an infection to see an infectious disease expert and to be exposed to your committee?
All of the infectious disease physicians in our hospital are participants of our committee. So we get feedback from all of them individually or as a group. They can also call the pharmacists. The pharmacists are available on the floor 24/7, 365, and they really know our bugs, they know our antibiotics, and they are very familiar with dosing.
Every single patient in the hospital on antibiotics are reviewed by pharmacists.
Every single patient?
Every single patient. We will help select the most optimum antibiotic choice for the patient, and we will make the intervention for the patient. We also put in a system in place such that selecting antibiotic is guided based on best practice without imposing on your workflow. On the background as well, we work with laboratory to basically report certain antibiotics, so it's like guided reporting in such a way that will also guide you select the antibiotic that we want you to select for that specific organism based on best practice.
The patient should know that at Washington Hospital, if they have an infection, this is not the old days where the doctor just picked something off the shelf, take this and we don't get better, we'll do something else.
Yeah.
It's very, very sophisticated and very safe, I think.
You're absolutely right. We have a lot of policy and procedure in place to help our patient, in which we can monitor the patient and make dosing adjustment, what's best for the patient based on this protocol. So the committee came up with those guidelines, and we provided education to the pharmacists so they always have the best tool possible to monitor the patient.
We've also helped out the surgeons by helping them in terms of patients coming in for elective surgery, how to best protect them when they need antibiotics and when they don't need antibiotics. So we've, in the background, tried to give you as much information built into the computer right at your fingertips.
Well, luckily, our rate for the superbugs in our hospital quite low in comparison to many other hospitals.
The other thing is we're actually improving. We used to have almost 50% methicillin-resistant Staph aureus, and it's dropping.
Yes.
And I do want to point out that we do have superbugs, but we also have super pharmacists, super docs, and a super hospital. We'll return after these messages to learn how Washington Hospital has implemented its Antimicrobial Stewardship Committee, how it's working to reduce antibiotic overuse and to prevent the spread of superbugs, and how the committee can help save lives. In days gone by, the antibiotic penicillin was the gold standard in the treatment of many bacterial infections in many people. Now, many types of bacteria have developed resistance following extensive use and sometimes improper use. Today, there are over 100 antibiotics available that target dozens of unique infections. Every case must be analyzed and monitored to ensure the correct treatments are prescribed for positive outcomes. With me again for this segment is Committee Co-Chair Lina Huang, and we're joined by infectious disease specialist Dr. Jevon Tang and intensivist Dr. Rohit Arora. Welcome. Dr. Tang, let's start with you. What are the departments that play key roles in the implementation of Washington Hospital's Antimicrobial Stewardship Program?
The short answer is everyone.
Everyone?
Right, from doctors to nurses to pharmacy, laboratory, environmental control. Everyone is important in contributing to the Antibiotic Stewardship Committee.
So like a lot of problems, it's very complicated, but there's a human solution. And the more people involved, the better.
Yeah, from our experience, since we started the program, we've realized that bringing in the multiple discipline approach actually provide better care to our patients.
We've been very lucky, though, in our institution that we have the support of our administration, such that we can have this multidisciplinary, which means everybody is involved in our committee to help us ensure not just from the part of antibiotic usage, but also in the prevention for the infection from happening to begin with.
Well, Dr. Arora, you're our intensivist, which are our superbug fighters, our dream team when it comes to really sick people. Tell us a little bit from your perspective. How does this team approach work in the intensive care unit? Isn't it sort of one man, one bug, one disease, one cure?
Thank you, Dr. Mehigan. So when patient comes to the ICU, they're really sick. So at that point, what we do is we take shotgun approach. We try to correct the disease, the process, as soon as possible with the strongest antibiotics. And as patients become more stable, as the labs indicate that patient is becoming better, and we get input from various other departments, we try to peel back, we try to take off the antibiotics to make sure that the patients are getting appropriate antibiotics and we keep the side effects to the least. So that's, in a nutshell, the ICU approach to the antibiotic resistance development. Now, what we have, a unique thing in ICU is that it's a place where everybody gets together and contributes to the patient's care. So we have our multidisciplinary rounds where nurses, physicians, nutrition, physical therapy, pharmacy comes in and discuss the problem the patient is having and what can we do to fix the problem. We take input from all the various departments and make sure that we are using right antibiotics for the bug, and as well as we're doing our best to prevent the spread of infection to the next patient.
And this is a hospital-wide approach, but in the intensive care unit, if you go in there as a patient, you're surrounded by doctors.
You're right, the patient is surrounded by doctors, but also patient is surrounded by other very sick patients and with bugs that are resistant. So that is where the problem comes. That's where the patient who's the sickest at that point gets new bugs from a patient which is next door.
Anytime you have a resistant organism in the environment and you have a sick patient near the environment, transmission can occur. So one of the things that we do at Washington Hospital, in addition to curing the patient, we also put in place program such that we prevent this transmission from happening. Any preventive measure that we can put in place to prevent the patient from getting additional infection where they are in the hospital or getting any transmission from the environment and get to be cured as soon as possible are in place.
So when you're a patient at Washington Hospital, you notice that every time everybody who comes in to see you, they're all doing this. You go, what in the world are they nervous? But everybody does it. They're washing their hands. And incidentally, washing your hands, by the way, is not getting a sink and some soap and water necessarily, although that works very good. It's usually one of these little things. Tell us more about these individual little things that we're all supposed to do, but none of us have been doing in our ordinary lives. But now we do it at Washington Hospital because we want to be the best.
Absolutely. So your different kind of infection, they have different rates of transmissions. Most of them is preventable. For example, if you have a cough, you really should wear a mask. Hand washing definitely can decrease hospital-acquired infection by over 90%.
When I was in kindergarten, they told me to wash my hands. And I got a little tired of it after just once or twice a day. Now I'm washing my hands every 5 minutes all day long. Does it really work, or am I just...
It does, actually. That's a scientific study that actually has shown that really the key thing to prevent transmission of a disease is by washing their hands thoroughly.
And wearing a mask if you've got a cold?
Oh, yes, absolutely. When you have a cold, when you're coughing. And that's why the infection control department is important. They give us guidance on what kind of precaution should be taken.
We can identify patients who are colonized with this resistant bacteria so that everybody who's taking care of the patient know about it. We engage with environmental services so that when the room needs to be clean after the patient is being discharged home, they can do so in timely manner.
So this team approach and best practices where for each individual patient, if at all possible, we identify the bug that caused the problem, then we identify the drug that kills the bug, that solves the problem, and we monitor the administration of the drug with pharmacy, infectious disease, intensive care physicians for the best outcome.
What they do is make us aware of this problem and help us to take measures to decrease the resistance. Once we know what bug it is, we can change the antibiotics. If the bug is superbug, as you say, then patient needs to be on super antibiotics. But the bug is regular run-of-the-mill bug, then we need to use antibiotics that is not so strong. We need to use gentler antibiotics, make sure that the bug is taken care of and the resistance doesn't come up.
So let's just take one thing that's in the papers all the time, C. diff. How did it get to be a superbug? What are we doing about it, and are we succeeding?
It may come to a surprise to you, but actually C. diff has been around for a long time. It's actually in our colon. Why recently it catch attention is because of the over-antibiotic use. Okay. So it kills off our good bacteria in our gut, and this bacteria was left untouched.
C. diff stands for Clostridium difficile, and we're looking at up to 14,000 deaths a year in the United States. It forms spores, which are really hard to destroy. That's how the bacteria spreads itself, and it makes really small shells, and it takes about 2 hours at 171 degrees Fahrenheit to destroy that shell.
So we've created this monster.
Yes.
We have to use Frankenstein's law.
What is that?
If you create a monster, you have to take care of it.
You have to take care of it.
Oh,
so
okay.
how do we take care of this monster?
So what we do is we do early screening and detection.
So we try to pick up
patients, yes. pick up carriers who might have it. We isolate them preemptively. We make sure that we are protecting other patients, staff, and the patient from getting the C. diff, and we do rapid diagnosis. And if the patient comes out to be positive for C. diff, we keep the isolation on and we do treatment for that. So we do early screening, detection, treatment, and education. Education for the staff, education for the family, and we also, when the patient is being discharged to the nursing home or the rehab centers, we do convey that patient came out positive and they should be careful about the thing.
The environmental services definitely play an important role in decreasing environmental burden. We talk about spores, so anytime a patient with Clostridium difficile being discharged, they will come in and clean the room from top to bottom, following the CDC recommendation on how to clean the room. That is one of the important aspects of the whole program.
Well, thank you for your service to our hospital and our patients. We're going to have a commercial break. Next, our panel of experts will discuss the results of Antimicrobial Stewardship Committee's efforts, the future of the program, and what the community can do to help prevent the spread of superbugs. We'll be back after these messages. Washington Hospital has implemented many measures to ensure safe and responsible use of antibiotics with excellent results. Outside of the hospital environment, however, there are a few things people at home can do to help curb the misuse of antibiotic medicines. Joining me for this final segment are Dr. Dianne Martin, head of the Antimicrobial Stewardship Committee, Dr. Jevon Tang, infectious disease specialist, and Dr. Lina Huang, co-chair of the committee. Dr. Martin, how would you evaluate the results the committee has seen so far?
Dr. Mehigan, they've been very good. We measure ourselves against several national standards where we look at our use of antibiotics, and we also measure our C. diff rate as well as our other infection rates. We are at national average or sometimes better.
The program that we put in place has been quite successful as well in terms of antibiotic usage.
I think we've illustrated pretty well. We're working as a team, we're trying hard, we're doing better all the time. Can we go through some simple steps of how, if you're a patient out there, or a family member of a patient out there, or a patient to be out there, or just anybody at all who might be sick someday, what can you do to help the Washington Hospital team take better care of our patients?
Well, it's just like what your mom used to tell you, wash your hands, because we think that going into the hospital or seeing patients, if you're a visitor or a family member or physicians going in to see patients, if we're washing our hands, we're preventing any carriage of infection into the patient, and on the way out, then we're preventing any carriage of infection from that patient outwards by washing our hands both going in and coming out.
Also at home too, when you do care for a sick child, you do want to wash your hand often so that you don't transmit the disease to your other child or even to yourself. And this is one of those things when we talk about antibiotic stewardship, by preventing to get sick yourself or to get your other child sick, you actually decreasing the amount of antibiotic being used in your household, and again, in the long run, will also decrease the resistance.
And Dr. Tang, when we say wash your hands, we're really, this alcohol thing actually works, right? If you have that, it's not just a show thing, isn't that right? It actually works really well.
It works, and I think if you read the bottle, it says it kills 99.9% of the germs.
That's another question. A couple times you said, make sure the patient takes all their antibiotics. You get a bottle full of antibiotics. You feel better in 3 or 4 days. So why should you continue taking the antibiotics even though you're all better?
When you're starting taking the antibiotic, the first organism that got killed is the sensitive organism, not the resistant one. So if you do not complete your entire course, you actually allowing a big chunk of organism to survive and start sharing how to resist the antibiotics next time. So it's very important to complete the course.
So if I don't finish all the stuff, there may be some bugs lingering in there that can come back and I get sick again.
Exactly, and then you have to retreat it with another course of antibiotic, which in turn is a longer antibiotic course. You may be given a different kind of antibiotic that generate your different kind of resistance. So that's
so the pharmacist and the infectious disease people know that to kill a certain bug, it takes a certain dose of a certain antibiotic,
And
but
certain
for a
length.
certain period of
Yes.
time as well.
Yes.
The other thing we'd like to emphasize is people getting the flu shots.
The
So
flu shots.
even though from year to year it may not be as comprehensive as we would like, the more you get the flu shot year after year, your own immunity builds up. So we think that getting the flu shot every year is very good health prevention, both for yourself and for your community. We don't want someone who's ill going to work and spreading the bacteria and the germs. So a lot of times we tell people, if you're sick, stay home.
Sick, stay home.
That's important. If your child
What if you
is-
can't stay home? What if I have an evil boss? What do you do instead of staying home? You can't
Well, I
stop
think-
coughing or sneezing.
It's better to stay home than to share your illness with your coworker, because then your coworker will get sick and there will be more people will be off from work. So it is better to actually stay home.
I agree, but in cases where you really have to go out, I would just suggest you wear a mask.
To wear a mask.
So you tell your boss,
Absolutely.
look, if I show up and I give everybody in the whole team the flu tomorrow, so it's better just to lose me rather than the whole team go down tomorrow.
Absolutely.
Right. I
So the
think
way to stop this is just to prevent it. I mean, you got to get the flu from somebody, right? You don't get it
You-
from all by your lonesome, just sitting there in the park.
Absolutely.
You have to
and-
catch it from somebody else who has the flu.
And I'm sure your coworker will
okay.
appreciate. I'm sure they don't want you to get sick. They rather see you wear a funny mask.
yes.
Yeah. So you
Yes.
take your flu shots.
And
okay?
I would expand to that all other vaccination too, Dr. Martin,
Mm-hmm.
right? Any other vaccination. Keep up with your vaccination.
But don't those things sometimes cause, if I get a flu shot, can I get the flu?
That's a myth.
Yeah.
That's a myth?
Maybe you will have a little bit side effects from the flu shot, but not necessarily the flu itself. The shot itself has a side effects to it.
Okay.
If the flu symptoms that you are referring to, the low grade temperature, all those are your part of your immune system trying to generate the immune response to the flu shot. So that's the indication that actually the flu shot is working. But is it actually the flu that's causing the symptoms? No, because the flu shot is actually not a live virus vaccine.
And finally, when you come into our house, Washington, we're very proud of, please follow the rules, right? I mean, if someone says, put the yellow gown on, put the yellow gown on, okay? Wear the gloves, wear the mask, wear the hat, pay attention to these rules, just like you see the staff doing.
Yeah.
Anything else we missed?
Don't pressure your doctor for antibiotics.
One.
Many common illnesses like cold or even some eye infection or ear infection are not necessarily caused by bacteria. They could be caused by viruses, and antibiotics do not work on viruses. So I think it's important that everybody practice stewardship.
Many times the patients feel that the antibiotics, again, the miracle drug, will make them feel better or their child feel better in 24, 48 hours, then they can go back to work or back to school. And if the physician says in their judgment that an antibiotic is not the right course, I'm hoping the patient will understand and not feel that they are getting less than adequate care. I think they're getting the best care.
So stick with what your doctor says. Don't go home and take the antibiotics you took last time for a while, but you forgot to take the rest of them.
Yes.
Stick with what your doctor says this time.
Yes. Your doctor not prescribing antibiotics, like Dr. Martin said, could be the best course.
That's right,
For
because you
your
may not
family.
need it at all.
And you may have side effects from
And you may
antibiotics.
be
Yes.
allergic to the stuff or have side effects or
Yes.
give it to somebody else. So, well, on behalf of our audience, I hope to speak for them and also myself because I learned a lot. We thank you very much for the program today, for your enlightening comments. We also thank you for services to our hospital. It's our hope that the information you've been given by our guest experts will help all of us better understand antibiotics, their value, their virtues, their dangers. And you can see, working together, we can slow the spread of superbugs in our community. Thank you for watching. We'll see you next time on Voices in Health. To learn more about antibiotics, visit the Centers for Disease Control and Prevention site, www.cdc.gov. Thanks very much.